How can plans use behavioral economics to achieve better outcomes? We'll find out on this episode of ShiftShapers.
Change either energizes or paralyzes. The choice is yours. This is the ShiftShapers Podcast, bringing the employee benefits industry interviews with individuals and companies who are shaping the industry's shifts. And now, here's your host, David Saltzman.
And joining us today to discuss that very topic is Matt Loper. Matt is CEO and co-founder at Wellth. Welcome, Matt.
Hey, David. Thanks so much for having us.
It's our pleasure. Always ask this question. Tell us a little bit about your background, because people usually have circuitous paths in our industry to where we're doing what they're doing today. How do you get here?
Yeah, do you want the long version, the medium version, or the short version?
It's your 25 minutes. Spend it how you want.
Awesome. Yeah, so I'll give you the medium version.
Okay.
I was a bio nerd all growing up, wanted to be a biologist, wanted to start biotech companies someday. Went to college and studied bioengineering, and very quickly learned that all my professors were literally the top in their field, and worked 30 years in a lab to hopefully find that one discovery that became a life-saving therapeutic. So realized that I was almost certainly not as smart as them and didn't have the patience to wait around 30 years to see if I had that 1 in 30 chance. So figured out how do I get into the healthcare space, or the biotech space specifically, more quickly. Went to Wall Street to try to learn how to value companies, invest in companies, hopefully help start many biotech companies a year. At that point, got put, like many things in life, by chance onto a project working with, at the time, Anthem, now Elevance. And this is 2010 or so. We were hired by the board to kind of do a complete strategic review of their business. And at the time I was like, health insurance, that's so boring. I wanted to do the cool biotech stuff.
Mm-hmm.
But it ended up being by far the most fascinating project I worked on. Saw, kind of all these changes coming to the market with the Affordable Care Act being implemented, with value-based care coming online. Went on to an investment firm and had the idea that, hey, maybe I won't save lives creating new proteins or drugs or therapeutics, but maybe I can help save lives using behavioral science and technology. So we've been at it for about 10 years now. It's been by far the hardest thing I've ever done, probably 3 times harder than I ever expected. But now that we're at a point where we can actually measure the impact we're making on the populations we serve, it's at least 10 times as rewarding. So it's been a long and strange journey, but I wouldn't have it any other way.
So let's talk a little bit about the problem that you're working on solving. Where did the interest come from? What's been the glide path of starting and learning and getting to where you are today?
Yeah. So the problem that we're fundamentally solving is that the folks who really are driving cost and quality most for the health plans we serve tend to be the folks who are least engaged, quote unquote, in their own health. And that word engagement is a loaded term, right? But when we think about engagement in any other area of our life, we think about things like, I'm going to sit down and watch one episode on Netflix, and then 6 hours flies by and we binge the whole series, right? Or I get in this TikTok or Instagram loop where I'm scrolling for hours, right? That sort of engagement where we're just totally hooked is completely different than when we talk about member engagement or patient engagement in healthcare. So in healthcare, when we think about engagement, it's receiving a text message or receiving information about things that you should go do, right? So we fundamentally had the thesis from the very beginning that the folks who need the true engagement the most are those who are, not going to respond to any sort of just outreach and saying, hey, you should go do these things, or more information about why they should go do them. What we really thought from the very beginning was, in order to actually change these behaviors and improve the outcomes to cost and quality, we had to serve this very hard to reach population. Usually it's folks who have Medicare, Medicaid, or dual eligibility. Usually it's folks who already have many chronic conditions or behavioral health conditions or both. And usually it's folks who are already disengaged or non-adherent to care. And in this population, we really tried to understand why are these folks not paying attention? Why are they not following through, right? And how do you use behavioral science, behavioral economics, technology, kind of now a lot of the new LLM and chatbot and AI stuff to truly create that level of engagement that a TikTok shoots for in healthcare. So what we like to talk about is, hey, we can work with a senior population. You can give us the people who currently aren't enrolling in care management or any of these programs, and we can get those folks to be 3 times as engaged on a daily basis over the course of a year than TikTok does in teenagers. So that's what we're trying to fundamentally solve, is that behavior problem, that attention and behavior and habit problem in healthcare that leads to cost and quality outcomes for the plans we serve.
And you're not owned by the Chinese government, so that's even better. So why, in short, why aren't people adherent to stuff that they know is good for them? Is that just human nature? And how do you bring them back into the fold?
Yeah. So it is based on how we evolved as humans. Our reward systems in our brains are motivated by the instant and tangible gratification we get from doing any behavior, right? So we aren't good at looking at the long term. This behavioral economists call this either hyperbolic discounting or present bias. We're biased towards the immediacy of the behavior or the reward we get from doing that behavior. So, perfect example is when you get a new puppy, right? Like my dog up here, you can see, when you train that puppy, they say, as soon as they do the trick, give them the treat right away, right? So that immediacy is really important. So we know what we should do, right? There's all the general wellness things that people know, like we should eat healthy, go take certain number of steps a day, work out, whatever it is. But for these folks that have chronic diseases, behavioral health diseases, substance use disorders, right, the stakes are even higher. And the number of things that they know they should do over the course of the day are numerous, right? Take all your medications as prescribed, show up for all the doctor's appointments, track all the metrics on a daily basis, right? Close care gaps, kind of do all that every few months. And so there's a daily component to this, managing these conditions. So we know as, humans, we've been told, like, hey, if you have high blood pressure or type 2 diabetes, like, you should be taking that blood pressure medication or that metformin. We know it's going to prevent that heart attack 4, 5, 10 years from now. But when we take that medication right now, we feel no different right now, right? So that's that present bias gap that creates this gap between intent and behavior, right? We know the things we should do. Oftentimes we intend to and want to do the right thing, but if it doesn't give us that immediate gratification, we often don't end up doing it. So we, for 10 years, have tried to combine all sorts of concepts from behavioral economics, habit science, motivational interviewing, peer support, all these different approaches into one program that gets a hold of more folks, gets more folks to enroll in and start using, and then gets them, again, very hooked to this daily behavior. So 91% of our users give us their daily attention. Every day they're giving us their daily attention and completing these behaviors. So that each point in time, right, what I like to say is, if you're going to try to create change to cost and quality, you can't cram for the test, right? You can't just study the night before, right? You can't just turn around a 3-star Medicare Advantage plan into a 4-star plan at the end of the year, right before the end of the year, right? Every day, if you just create this relationship with the member and every day create this gentle nudge towards these right behaviors, over the course of time, you're going to create exponentially more improvement than if you just try to give them a shove once a year and push them in the right direction once a year.
Can you quantify the problem? I mean, what is this costing us?
Yeah, I think if you just think about stars ratings as the one, example of one problem we solve on behalf of health plans for Medicare Advantage plans, right? This is a huge, huge financial problem, right? Last year, CVS Aetna lost $1 billion of stars bonuses. Centene and Elevance each lost about $500 million of stars bonuses. So the financial implications are huge. And when you look at how stars ratings were calculated previously, about 2/3 of stars ratings were the things that the plan controlled. So admin measures and caps. So do you have a call center that picks up the phone on time? Do you adjudicate claims on time? Do you have a network that your members are happy with, right? Now, this year going forward, 2/3 of the stars metrics are based on the things that the member controls, right? So Part D adherence, HEDIS outcomes, health outcome surveys, health equity index, right? These are the things that now, like, you have to, if you're going to be a profitable Medicare Advantage plan, you have to hit stars bonuses. CMS is purposefully making it harder to hit stars bonuses. And now the things that you need to improve in order to hit those bonuses are all in control of the member. So that's why, we think it's so crucial, especially Medicare Advantage right now, to have a strategy to influence these daily member behaviors that impact these end metrics.
How do you reach out to folks? Is it like an initial human reach out and then an app after that, or is it human all the way through? How do you do that? And also on your intake, how do you determine? I mean, years ago they used Prochaska protocols and those kinds of things. How do you determine whether a member is actually ready to make change?
Yep. Yeah. So on the first piece, selecting for the membership that we're most interested in. Actually, we try to select against ourselves, right? We try to select for the people who are least adherent, least open to change, because those folks tend to have the highest impact on cost and quality, right? And then how do we reach out? Well, it's a lot of, learnings over the course of 10 years and millions of data points. So even just down to, who reaches out to which member at what time with what message, right? So if we're enrolling let's say a Medicaid single mother of 3 in New Mexico, right, we might reach out on the weekends because she might be working during the week. And we've learned that over time through, hundreds of thousands, if not millions of other contact with other members from the exact same demographic versus the Medicare Advantage member in Grand Rapids, Michigan. Maybe we've learned that calling them at Tuesday at 3:15 p.m. during the first commercial break of Price is Right is the optimal time to get them on the phone, right? So just getting their attention is the first step. We do a lot of other things, like here's an example of a postcard that is one of our clients' Gold Coast Health Plan, one of the great county-based health plans here, Medi-Cal health plans here in California. And we reach out with a postcard that looks like it's a handwritten note. Well, guess what? This was written by a robot. But it just tries to reach the member in the right format over the course of time so that then when they get that phone call, they already have knowledge about the program, they know what it's about, we can answer their questions and get them enrolled into the program as easily as possible. Then once they're on, the app does all the work, right? So the daily engagement is all through the app. For example, let's say medication adherence is a key portion of this program with Gold Coast, right? That member might get a notification, it's time to take your medications to avoid the loss of 2 of your $30 that we already endowed you, right? So that extrinsic reward, that part of behavioral economics that we use to get more people to sign up and then create this behavior is then tied back to that immediacy, right, that we talked about. So they open the app, they snap a photo of the pills in their hand, and they get this instant, graffiti or the confetti comes out, great job, you've kept your $2 for the day, right? So that engagement on a daily basis and the reinforcement on a daily basis is all handled by the app over the course of time.
That's interesting. It's kind of like getting likes and getting that little endorphin rush that happens when, even though they're meaningless, in this case, they're pretty meaningful. Do the plans that you work with, just an oddball question, do the plans that you work with market this as a feature of the plan?
Yeah, so we are very careful not to do that for a few different reasons. We're a quality improvement program. We're not a supplemental benefit, so we're not offered to the whole membership, especially Medicare Advantage.
I see.
So we don't want to create any perverse incentive to sign up for that health plan or undue marketing efforts that would run afoul of any CMS guidance. So we're very careful not to do that broad messaging. However, once the member is identified as an eligible member for the program, we try to do very, very targeted and strong messaging to that member.
And now, a word from our sponsor. This episode is sponsored by MZQ Consulting, a concierge compliance firm that excels at making the complex simple. Have you seen the news lately? Johnson & Johnson is being sued because J&J's health plans failed to negotiate lower prices for prescription drugs. In the case of one drug, the plan paid $10,000 for a drug that regularly is available for under $80. Not only were the members of the benefits committee named personally, but their benefits advisor was also named in the suit. And that, dear listeners, is why you need a top-flight compliance firm. Yes, MZQ handles all the usual compliance stuff from ACA reporting and tracking to wrap documents 5500s, mental health NQTL and QTL analysis, and a whole lot more. But the heat is being turned up on fiduciaries who don't act like it. In this environment, using an ERISA attorney-led compliance consulting firm is your best strategy. Your clients too. And MZQ Consulting is where you should go. For more information, go to www.mzqconsulting.com or email them today at engage@mzqconsulting.com. Now, back to our conversation.
So it sounds like the app does a lot of push stuff. Does the member also have the opportunity to call in and ask questions and interact?
Yep. Yeah. So, we take on all of the program support related to the program itself on behalf of our health plan clients. So yes, absolutely. Members contact us. About 80% of the questions come through text message through the app. About 20% come through phone calls. But there's been cases where, we have one anecdote of a Medicaid single father who was going through some housing insecurity issues, had 4 children, and the health plan that we worked with, the Medicaid plan we worked with, had a full team of case managers to help with this exact issue with like housing stability. The member wouldn't talk to the health plan case manager. It was this game of telephone where they were interacting with us every day through the app. They were texting us through the app, giving us updates on, hey, we need to get birth certificates for all 3 or all 4 kids. And then we would pass that information back to the case manager. The case manager would say, okay, tell them this, because they trust us, right? Once they start using the app every day, they trust our team more than they trust the health plan's team, and they see us as this nice extension of the health plan. So it's a very tragic example, but one where, because of this daily relationship, we were able to serve the needs of both the health plan client and the member in a moment of crisis in a way that we never were designed to, right? And this daily interaction is the thing that generated that touch point in order to solve for those that emergent situation.
Yeah, well, I mean, pretty much every study that I've read over time is that success in this area all revolves around trust and building trust relationships. Are there other ways that you do that, just in addition to people just using the app on a regular basis?
Yeah, and I think it comes back to our number one core value as a company is the member is the mission, right? So when we think about our personal goals or our company goals, it's all in the form of how do we serve the members? How do we grow, not for financial metrics, but because we want to scale the impact we've been able to generate? How do we, in any situation, show up in a way that is in the best interest of the member and not ourselves, not our company, not the health plan? Yes, we want to make sure we serve the needs of the health plan, but if there's ever an example, which luckily in almost every case, the interests are all aligned, right? What is best for us is best for the health plan and best for the client, and best for the member. But if there was ever an example where there's a question, it's always choose the member first, right? So I think that is a very basic thing. But if you start your organization and your culture with that core tenet, and every all hands meeting or every board meeting, we start with playing a member testimonial and the videos that our members are sending back to us, and it reinforces that mindset that hey, we're always doing what's best for the member. And that little thing, again, compounds over the course of time. Sure. And builds. And then, your support agent who, is new to the company, gets that ingrained in their mindset. And then they show up in a way when there is that situation in a way that serves and builds trust with that member. So I think it really impacts everything we do, from how we design our app and our technology, how we sell to the market, how we serve the members on a daily basis.
For a long time, when we talked about compliance, we were talking solely about medication adherence. It sounds like you guys do a whole wide range of things. When you engage with a plan, do they have the opportunity to tell you what they want to zero in on? And how does that work? And then do you find that those engagements expand over time after you've shown success in whatever area they're initially interested in?
Yeah, absolutely. So medications are still the primary focus for, at least initially, for a lot of these members and a lot of these use cases, because they are going to be the highest impact behavior you can change to improve STARS outcomes and improve cost of care. So across all these different condition sets that we serve, medications are probably still the primary use case in every single case. So to put hard numbers on it, we'll verify about 20 million member behaviors this year. Over 80% of those will be medication-related tasks. However, to your point, there are so many other behaviors that have to happen either on a daily, weekly, quarterly, or annual basis that also impact the outcomes of that population, right? Mm-hmm. So we've done everything from care gap closure, right? Showing up for A1C visits, showing up for even dialysis appointments. We worked with DaVita on a really cool pilot where we were able to show an improvement to not just the daily medication adherence, not just people who have ESRD or on dialysis have very stringent nutritional guidelines. They have usually many chronic conditions beyond, just that kidney disease or that ESRD. And they still have to show up in a dialysis center 3 days a week and sit in that chair. And a lot of these folks might be frail or elderly or not have the ability to get to that appointment, right? So we were able to show that even that behavior of showing up, we could improve drastically. We've done a lot of remote patient monitoring use cases where most of our Medicare Advantage populations have, a daily remote monitoring behavior, whether it's blood sugars or blood pressures. So basically we started very focused on the medication problem, but since the framework and the technology we've built is all about changing behaviors and framing these behaviors in the form of new habits, we've been able to extend beyond medications to any behavior that impacts cost and quality.
And I would presume that you're also pretty heavy on metric delivery and data delivery to the plans. Is that something that they have access to on a regular basis, or is that a quarterly, or how do you guys do that?
Yeah. So there is daily reporting that is available to some, like care management and some of the clinical pharmacy team on the more real-time stats on an individual metric basis. But really, for more of the executive layer or the buyer, the champion of the program, we're doing quarterly business reviews where we start looking at those hard outcomes as it relates to claims, so cost of care and utilization reduction, and also those key quality metrics if it's especially a Medicare Advantage plan that's trying to improve their stars ratings.
So you're 10 years into this. Where do you see yourselves in 5 years?
Yeah, it's interesting because it's like we've been doubling, if you're using members enrolled or therefore revenue as the primary metric, we've been doubling our member count and our revenue every year for the past 4 years. And we're now, it's so fun because it's 10 years in, but we're really just getting started, right? Like it's one of those classic, like overnight successes, 10 years in the making, right? So, especially in the Medicare Advantage and D-SNP space, we're seeing so much interest that, I think in 5 years, we hope to be the standard, right? We think that, just like every company needs a CRM and eventually every company ends up buying Salesforce, whether it's, a good or bad thing, right? Eventually you all end up on Salesforce. We hope that someday every plan, either a Medicare, a D-SNP, or a Medicaid plan, has a line in the budget and says we need the daily motivation tool to get our members to better cost and quality outcomes. And Wellth is the de facto, monopoly in that space because we have, now at that point, 15 years of data and hundreds of millions of data points, and we're able to serve, these populations in a way that no one else can because we have all those data insights on how to best change those behaviors to impact those end outcomes to cost and quality. So, we're going from like this startup phase to now, we're kind of like trying to become the category defining and hopefully someday industry defining company in the space in terms of improving cost and quality outcomes.
That's awesome. And a great place to end our conversation for today. Matt Loper, CEO and co-founder at Wellth. Matt, thanks for an interesting interview. We appreciate it.
Thanks so much.
Shout out to the crew at Grand River Agency for their awesome post-production. This ShiftShapers podcast is copyrighted content and may not be reproduced in whole or in part without the express written permission of ShiftShapers Solutions, LLC. Copyright 2024.